So before I actually even go any further, I must tell you who Nadia McFarlane MD is, since clearly that's not my name. So that was one of my best friends in medical school. She helped put together a few of these slides when we did a presentation together during medical school about spiritual history assessment and training. All right. So first, I'm just going to touch on Jesus as our healer. We'll look a little bit at religion in America and how that leads to the need for a spiritual component in healthcare. Then I'll talk about a case, an example of addressing that spiritual need. Then we'll look at barriers to why that doesn't happen more frequently. And then I'll help you with some tools for your own toolbox and how to do this or adding to your toolbox that you may already have. So this is a verse that many of you may be familiar with already, Matthew 9, verse 35. Jesus went through all the towns and villages, teaching in their synagogues, proclaiming the good news of the kingdom and healing every disease and sickness. So here we see that there's a combination of caring for the patient's spiritual health as well as their physical health. And I found a nice picture online that just demonstrates that a little bit. A picture is indeed worth 1,000 words. So here we see Jesus being a healer for children, men, women. I'm not a surgeon or a surgery resident, even though I did think about it a lot in medical school. So I also wondered, is there a picture, for someone in medicine who's not a surgeon? I found one with a businessman. So I thought about interesting, It is great to have Jesus in the marketplace, whether we're physicians or some spouses or friends are in business. But I eventually did find one that was more relevant to me as a physician scientist, thinking about my patients, caring for them, even if not in surgery. And I really loved this one. I thought of myself as this girl in that yellow and white dress, thinking about my patient, caring for my patient, and thinking about Jesus' compassion for that patient. I think of it as in this picture. And you know that song? Some of you may have heard the song, "For I have touched the hem of his garment, and his blood has made me whole." You know that song, right? So I think about, I don't know what these hands in the pictures are doing. Maybe this hand is trying to say, get down. Who are you to touch him? But I hope these hands are saying, why don't I help you get to him? And I think that's part of the role that we play with patients in helping them deal with their suffering and their healing. And do patients actually want that? What is the distribution of faith in this country, for example? And this study, admittedly, is a little bit old. I'm sure there's new data out there. This is from 2001, showing the distribution of faiths endorsed by people in this country. And you'll see that the majority endorse Christianity in some form. We don't know what it means to them all, but it far outweighs all the others. And that's relevant to us when we think about the interaction between our faith and our patient's faith in medicine. So is there really a need to even talk about this? I know that Scott touched on it, but is there data out there? We know that in medicine, and maybe having been science majors or French majors or whatever majors we were before becoming doctors, we know the power of data from scientific literature. And here, for example, is a study from Ananda Raja et al. It was in the American Family Physician Journal in 2001, and it showed that 77% of patients surveyed would like to have their spiritual issues considered. And only 10 to 20% of those patients reported having that addressed by their physicians. So we start to see here that there is a dichotomy between what patients want and what physicians are willing to provide. And then there's another study by King et al., by Dana King and Bruce Bushwick. And Dana King was a professor here in North Carolina, University of North Carolina, and now he's down at University of South Carolina. So I don't know if some of you may know him. And this study here showed that 94% of hospital patients thought that their spiritual health was as important as their physical health. I want you to think about that. 77% of patients thought that physicians should consider their spiritual needs as important as their physical needs. And yet 80% of the patients felt that their physicians never or rarely discussed their spiritual health with them. And here's another study done in patients at the Dana-Farber Cancer Institute at Harvard in Boston. And this study found, this one was done more recently in 2012, it was published. 68% of the patients felt that religion was very important to them. 89% of patients felt that religion was at least somewhat important. And so the medical team decided to provide spiritual support for patients and study the difference in outcome. So looking at the odds, if the spiritual support was provided for a patient by the medical team, the odds were that the patients were 3 times more likely to spend their final week of life in hospice. These are cancer patients or patients with cancer. And the patients would be 3 times less likely to need aggressive care in their final week of life, and 5 times less likely to die in the ICU. And when the family caregivers of these patients were surveyed, the families showed that patients had a better quality of life near death if they received spiritual support by their medical team. So that reminded me of a case of a patient I had in November 2012 at Mayo Clinic, where I'm a resident in internal medicine. We had a 94-year-old female who came in with hypoactive delirium, meaning she wasn't agitated pulling her IV out of her arm. She was just really confused and quiet, didn't know where she was asking for people who weren't there. And that was thought to be due to her not really eating and drinking as much in the past several months. She also had a low red blood cell count with some anemia. She had low platelets, and no one had yet worked that up or figured out what was going on. So she came in being confused some of the time, not eating for so long, feeling just weak all the time, tired, sleepy, or sleeping almost all the day, and she had lost a lot of weight. She also wasn't putting out much urine. Her shoulders didn't work as well for her anymore. Sometimes she had diarrhea, sometimes she was constipated. Sometimes she just didn't have any control over her bowels. And she had recently sprained both of her wrists. We ended up diagnosing her during that admission with presumed myelodysplastic syndrome. Her bone marrow wasn't working as well. It's sort of thought of as being like cancer. And she also was diagnosed with atrial fibrillation. Her kidneys were failing acutely. She was diagnosed with pneumonia because she just couldn't swallow her foods or her liquids. And when she was admitted, she actually had said she felt like she was slipping away. And she had started having those conversations with her niece, her primary caregiver, a few weeks before she came into the hospital. And she started telling me, whenever I went in to see her, she started saying things like, I don't know why you're doing all this stuff. You know, you come in and do all this stuff to me, and I don't know if I want all this. I don't know if this is what I want. So then we realized that perhaps we needed to have a conversation with her. What do you want for your care? We make our own assumptions of what would be the best aggressive treatment for you, for whatever you have, but what is it that you want? Ultimately, it's your decision as you come in for care. So we had a goals of care conversation with her, and she ended up declining any further lab testing, declining any more checking blood pressure or her pulse. She declined aggressive therapy overall, and she just desired to be comfortable, and that's what she wanted from us. And then as we sat there, I was sitting in a chair next to her bed, and my senior resident was kneeling because there wasn't another chair in the room, and her niece was sitting next to her, and she was lying in the bed. And as we tried to understand her goals for her care, she was just talking about life in general, what was important to her. She was talking about the role that church, community, and giving play in her life. And as she talked about that, we thought about, if we're going to really address her needs at this time, what else can we do besides listen to her and make some changes to her treatment plan? So I have a question for all of you. With the various levels of experience that you've had, would you offer this patient prayer, given everything that she said? So I don't know if you would like to raise your hand or just think about it in your minds. Would you offer to call her spiritual leader, her priest, her pastor? Would you connect her with chaplain services in the hospital, which is a way that most hospitals fulfill the requirement to address patients' spiritual needs? Would you yourself pray with the patient? Or would you feel that prayer has no role in healthcare? So that's something for us to think about. What ended up happening in our case was I felt God saying to me, pray with this lady. And I thought, well, my senior resident is there. I don't know what take he has on this, if he has a faith, doesn't have a faith. Has he seen anyone pray with a patient before? So I thought, I don't know. I might, maybe, I don't know, let's see. So then my senior resident, he offered her chaplain services. So then I said, okay, fine. I'm just going to bite the bullet. I'm just going to pray. He can say whatever he wants afterwards. They could kick me out of the program. I don't know, because we haven't talked about this. So then I prayed for her. But the first I said, we're offering you chaplain services, and I want you to know that if it would be helpful to you, I'm willing to pray with you as well. And she said, really? So she held my hand and closed her eyes. So I didn't have too much of an option at that point. So then I prayed. I prayed that God would help her communicate to us what she wanted. I prayed that God would help us understand her goals, that God would help her team care for her in the best way possible, with whole person care. And I prayed that his plan for her would come to pass, whatever it was, and that she would have peace at this difficult time in her life, and that her niece would also have peace with whatever was to come. And then after the experience, we went back to the workroom, and I didn't know what my senior resident was going to say. And he said, Sherry-Ann, I think you did a great job with that patient. I think that prayer was really beautiful. That was great. So then I went to my little corner to process what just happened. And I overheard him dictating his note, and he concluded his note about the goals of care conversation with the patient, saying that prayer and chaplain services were offered during the conversation. And it was such a simple thing to put in his note, but I thought it was pretty amazing, given that it's not something that we talk about much in medicine. So I said to him, you put prayer in your notes? And he said, yes, is that okay? Was that a problem? And I said, no, that's fantastic. I love it. It's just great. Because the only other time I had seen a physician put prayer in their note during my fourth year, or during the past couple of years, I should say, was at Esperanza Health Center, a Christian health center in Philadelphia. How many people are familiar with that? There are at least 3 or 4. Good, so some people are familiar with it. It's a Christian health center in Philadelphia, and they have a program in the summer. I've not been paid to plug this. But for about 3 weeks, students can go from different areas of healthcare and go out into the community in twos, as well as having a social worker or physician there and a Spanish interpreter, going door to door, praying with patients, but offering blood pressure checks, blood sugar checks, and connecting people with churches in the community if they're interested. And then one of the afternoons during that experience, you spend at Esperanza Health Center. So I was working with Brian Hollinger, the medical director, and we prayed with patients, everyone that came in, and his notes would say prayer, 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 prayer. And I thought, are you allowed to do that? It's like, of course, it's standard of care. If I did it, it happened, and it's going to go in the note. And I thought it was really remarkable. So I guess I should add at this point that I've come up with a blurb that I'm going to start putting in my notes, because I've prayed with patients, but I still haven't put it in the note. And I think that's something for us to really think about for a few reasons. One, it happened, so it really should be in your note. And two, someone else will read it and say, oh my gosh, maybe this is okay. So this experience impacted her patient and her niece. The patient herself she really did seem more at peace after that encounter. Not only were we doing what she wanted, but she also felt that we understood her and cared about her as a whole person. Her niece also, who had been crying during their encounter, she also seemed more at peace. And in addition, her niece told me that when the chaplain came by after we put the order in, he was moved that her doctors felt that her spiritual needs were important enough that they prayed with her. And the way it impacted the team was that it allowed us to have that conversation. So my senior resident and I could talk about, oh, what's your faith? What's your faith? Have you done this before? What did you like about the experience? And then it turns out that our attending physician that week was Dr. Mark Nyman, who is the CMDA faculty rep for Mayo Clinic. So then we were able to talk about that, and then he was able to ask a third member of the team, do you have a faith background? And she talked about how she grew up, and she's not quite Christian, but she went to a Catholic preschool. So then it opened that conversation there too. And then there was a med student on the team who turns out knew Dr. Nyman from CMDA. You'd think everyone at Mayo Clinic was Christian, right? So then I was able to talk with the med student and say, you know, this is okay. Dr. Nyman prays with patients. I pray with patients. If it's something God lays on your heart, it's okay to pray with patients. So we're able to have that conversation because of the experience while we're all on this team together. All right, so I wanted to share all of that to encourage you to think about doing it at all or doing it more. The patient eventually developed bleeding in her intestines, and she had complications from a stroke. And she passed away about 10 days after her admission. And for her, it was a peaceful passing. So that was an impactful experience for me that I thought might be encouraging to you, might be inspiring to you, and that I thought relates to the data that I showed you about how patients feel in their last week or so of life. And there is more data out there. In another study done by the same facility as the last one I mentioned, the Dana-Farber Cancer Institute at Harvard in Boston showed that 80% of patients, nurses, and physicians surveyed felt that providing spiritual care was important and appropriate. 15% of patients reported that spiritual care had been provided to them. And every single one of those patients that had their spiritual needs addressed in the hospital reported a positive impact. And let's look at some more odds. For spiritual care training for physicians in this study, odds were that those physicians trained to care for their patients spiritually were 7 times more likely to provide spiritual care versus those that weren't trained. And only 14% had received that training. So as we go on, I want you to think about some of these numbers in terms of why this doesn't happen more frequently. So this slide has a caveat where there has been no randomized controlled trial. There has been no meta-analysis. And those are the standard, the highest standard of evidence-based medicine. These are more prospective trials, cohorts, case studies, not as much rigor. We talked about academic rigor earlier. Not as much rigor, so you sort of have to take it with a grain of salt, but know the data is out there. Suggesting a beneficial relationship between addressing spiritual needs and stress reduction, recovery from illness, pain mitigation, adjusting to disability. So vast numbers of areas of patient care and experience can be affected by this. In fact, this is what I was alluding to earlier in terms of standard of care. The Joint Council for Accreditation of Healthcare Organizations, or JCAHO, in 1999 recognized the influence of spirituality on hospitalized patients and mandated that a spiritual assessment be performed on every patient. Some of us realize that religious beliefs can affect the decision making, and I think the most famous one that's on board exams and in classes all the time is that those of the Jehovah's Witnesses faith do not accept blood transfusions. But there are other ways in which religious beliefs can affect your health care. For example, some patients believing that God will heal them may not adhere to medication regimens. And some of us may have had experience where patients refuse care and only refuse care in the hope that they will have a miracle. And everyone chooses what they choose for their health care, but it's important to know where the patient is coming from, what their beliefs are, and then you'll understand why they might be refusing care. So having that conversation about their faith background or how their faith impacts their views of their health will help you understand what's going on in the care of the patient. So, medical illness can often trigger spiritual distress in patients. Someone might ask, why is this happening to me? Did God forsake me? Why is God allowing this? Is it something I've done? And that spiritual distress can worsen the medical illness. And that's another reason to be aware of what the patient is going through spiritually. Now, why doesn't this happen more often? Uncertainty about how to address spiritual needs, lack of experience or formal training, not wanting to offend anyone, the belief that the role of the physician is separate and apart from that of a pastor or priest, an inability to correctly identify patients who desire those discussions. And it's that inability of figuring out who would want this that I want us to focus a little bit on now. There are quite a few tools out there in scientific literature. This is one of them called HOPE by that first paper I talked about, Ananda Raja, 2001. What are your sources of hope, meaning, or comfort? Are you a part of organized religion? Do you attend church? Are you committed to a support system at church? Do you have a personal spirituality or practice, prayer, meditation that might help you at times? Are there any effects of your faith on medical care and end-of-life issues that I should know about? There's another one called FICA by Dr. Puchalski in 2000. What are your faiths or beliefs? Do you consider yourself spiritual or religious? Does that have any importance to you? Any emphasis? Do you place emphasis on faith or belief in your life? Do you belong to a spiritual community? Are there any needs in that area that you would like us to address for you? There's another called Faith by King, 2002. I'd mentioned some of this study before as well. Faith, how does this apply to your health? What's your involvement? How does this affect your treatment? And how can we help address your concerns? So these are a few tools to be aware of in literature that you could use. And then this here just lists some of the questions that I might use often, or maybe a couple that I don't use but I could potentially recommend using. The first one is, as we said before, what are your sources of hope, strength, and comfort? And you can bring that up with any patient at any time because the patient is here because they're going through something. What helps to get you through difficult times in your life? I ask that one a lot. And then I might say, are there any practices that you find useful? Prayer, meditation, do those help you at all? This one I don't use often, but I think is important to have, and some hospitals have this on intake. Actually, not this one, the next one, sorry. This one isn't asked very often, but if you do ask it, you'll be surprised at the answers. Do you believe that your faith or religious belief can affect your health? And we sort of touched on that a little bit earlier. And this one that really brings home the point of asking these questions, partially. Would you like someone to pray with you? Of course, the underlying point is to share God's love with the person, help them think more about God in their lives, perhaps have God move them in some way. But your role in that, at that point, is would you like someone to pray with you? If you're not comfortable, bring in chaplain services. But I hope that after this talk, you'll be even more comfortable praying with the patient yourself. And some final thoughts. I have lots more. So during Q&A, more thoughts will come up. But for now, some semi-final thoughts. Taking a spiritual history indicates interest in the patient as a whole person and not as a disease. And this can strengthen the patient-doctor relationship. It can influence the patient's adherence to therapeutic interventions. If they trust you and feel like you understand them and you care to understand them, they might care to do what you're actually asking them to do. And all of this has to be done in a caring and respectable manner. And here's a quote from Dr. Josh UI in Philadelphia that I tried to memorize, and I have it here in case I forget some of it. If physicians and other healthcare professionals have sworn to treat patients to the best of their ability and judgment, and the best care treats patients as whole persons, then to treat patients in a way that ignores the fundamental meaning that a patient sees in their suffering, healing, life, and death is to treat patients superficially and to fall short of the best ability and judgment. So I remembered it all. I'm very proud of myself. And I memorized it because I have not yet faced opposition in doing what we're considering standard of care. Several people at Mayo Clinic, several people at University of Connecticut, several people where you are, several of you everywhere are praying for patients and meeting patients' spiritual needs as mandated by JCAHO in 1999. I've not yet faced opposition, and one of the biggest reasons is because it's all in context. It's in context of what the patient wants, and that's why it's so important to have tools to find out what the patient desire is and where they are right now. What is God doing in their hearts right now? So memorize that if you will, and if you ever do face opposition, I think that's a statement that could be helpful for all of us. Thank you.